Good morning, everybody. Thanks to the organizers for asking us to chair this session. I am indeed honored to introduce Dr. Sampath Kumar, my senior professional colleague, a teacher par excellence, and indeed honored to hear him about the hope that the HIF-PHI inhibitors are going to give. Are we going to stow away erythropoietin, or are they going to complement this? PHI is going to complement the erythropoietin in management of anemia of CKD is what we are going to hear. Sampath, as usual, will have a humorous end. Let us see. Over to you, Sampath.
Thank you, sir. Good morning to all of you. Thank you very much for this good opportunity to again discuss this molecule which has been discussed threadbare over the last 3 or 4 years. And repeatedly we have been inundated with the knowledge that has come in this new arena of nephrology. So, I will start with a quote from my professor MSP, who during one of his rounds, when at that time he was very much interested in the antioxidant systems, he casually made a mention that oxygen, is the true trinity. It is the Brahma, Vishnu and Shiva. We are born, we live and we die by oxygen. So it is oxygen is the ultimate electron acceptor in the process of oxidative phosphorylation in the mitochondria, which generate sufficient ATP from the catabolism of glucose and fatty acids. But as you know, life has got a balance in everything, and there is always an inherent risk of oxidative damage to the cellular macromolecules if oxygen supply is in excess. And hypoxia also has to be very finely tuned. And so hypoxia regulation determines the supply-demand matching. And these hypoxia responsible elements or genes are there throughout the animal kingdom, irrespective of the presence or absence of lungs, heart or kidney. So you can see that how much importance the nature has given for these hypoxia managing elements. And there are many who have tried to fit the jigsaw puzzles. It all started in the 1890s, in the 19th century. Angelo Moses's pioneering experiments in the Italian Alps, and then came the landmark Oxford Ale expedition of the Pikes Peak in Colorado. And then another piece of jigsaw puzzle was in the fact that these HIF target genes were upregulated in tumors of von Hippel-Lindau syndrome. And a curious fact was polycythemia was not seen in large percentage of these tumors, but in a very small percentage. Then another piece of the puzzle was this very small community in the Russia, Shiva's community, where they had a mutation in the VHL gene, which resulted in early death with a lot of thrombosis. And these mutations are also seen in and around the Naples, in the Bay of Naples, they called island of Ischia. So all these pieces were all put together by these 3 great people who were given the Nobel in 2019. And so we have the pathway of this HIF, how it generates erythropoietin and how they can be modulated. And you have the HIF-alpha and the HIF-beta. The HIF-alpha, 1-alpha, is mainly under the control of HIF-1-alpha dioxygenases. They have, these are the enzymes which fit the hydroxyl molecules onto proline residues of the HIF-alpha molecule. And whenever there is normoxia, these are working overtime, and they see to it that the HIF-alpha and beta don't get together. They are actually marriage separators. And once the normoxia is there, HIF-alpha goes and gets attached to the VHL segment, and then it is taken to the cleaners, to the proteasomes, and absolutely there is no EPO transcription. On the other hand, whenever there is hypoxia, this prolyl hydroxylase cannot act, and HIF is stabilized, and so they can go into the nucleus and attach themselves. HIF alpha and beta get attached, and there is translocation, and EPO gene gets transcripted. Not only EPO genes, but hundreds of HIF related elements are being translated, as we shall see. And so you have these inhibitor agents, daprodustat, roxadustat, all these we will see. So what are these targets? The PHT targets for VADA is PHT 3 rather than 2, and you have the different molecules targeting the different prolyl hydroxylase domains, and you have the molecule of desidustat which is targeting the PHT 1, 2 and 3. And the other aspect which has come when we investigated this HIF pathway is that they also seem to have a lot of role in how iron is getting mobilized. And you have, all of you know about this hepcidin, which gets terribly upregulated in patients with CKD, partly because of retention and partly because of inflammation. And this seems to produce shutting down of these the doors for iron absorption and also for the iron mobilization from the reticuloendothelial system. So once these prolyl hydroxylase inhibitors are acting, what happens is these doors are opened, and so there is better absorption from the gut and also better mobilization of the iron from the reticuloendothelial system. So you have an excellent mobility of this iron, and so that the erythropoietin and iron can act together to increase the RBC mass, and in such a way that you have another pathway of iron mobilization also in this. But unfortunately, because of the multiple other areas where these genes are activated, there seems to be increase in the vascular repair, endothelial health, and the inflammatory and erythropoietic factors. The molecules which are being tested in the clinical arena, the VADA, the ROXA, and they were all biting the dust and not given the approval in US, even though it has been approved in other countries like Japan and European Unions. Dapro, I learned that it has been approved recently in the US. And these are the large scale phase 3 clinical trials which have been done, and you see that hundreds and sometimes thousands of people were subjected to these molecules, and we have this Olympus and Rockies trial in the ROXA where Indian subjects were also included in the study, and I remember Professor Georgie Abraham also being one of the coordinators. Then the summary of this is that the meta-analysis has shown clearly that as far as the increase in the hemoglobin is concerned, it is equipotent with any of these erythropoietin molecules. And the safety, there are some niggles of doubt. So we have the secondary endpoints where it has been shown that the ferritin levels uniformly came down, and also some transferrin levels increased. The hepcidin levels came down. So all these are very reassuring facts that have shown a significant reduction in the ferritin and hepcidin, and there are no studies which have shown a significant change in the VEGF molecule, even though these are all very short-term studies. Some of these studies have shown significant reduction in the total cholesterol and LDLs. And this was the ROXA study in non-dialysis dependent CKD, where there was an allocation was done in a few patients with Darbo and all others on the EPO, and they have compared with the Darbo and EPO, and they found that there is it is non-inferiority. The important point is that there were some problems of nasopharyngitis, hyperkalemia, and hypertension. And what about the ROXA in pre-dialysis population when they were tested against placebo? It has been shown that placebo it was clearly superior, and the rescue therapy was required only in up to 8%, whereas rescue with erythropoietin, iron, or blood transfusion was required for close to 30%. So all of us are aware, and all of us have been experiencing this. The problem seems to be about the cardiovascular safety of ROXA in non-dialysis dependent CKD, and there were some issues that the hazard ratio was hovering above 1 about MACE and all-cause mortality, and that is the reason why the ROXA has been given approval for dialysis dependent patients in US and not for non-dialysis dependent CKD. And there was another group of studies on PROTECT, INNOVATE studies about the vadadustat. And it has been shown that vadadustat was non-inferior to Darbo, but again, the niggling doubts about the cardiovascular safety, the cardiovascular mortality was slightly on the other side, favoring Darbo. Again, there were some doubts. So we have the Indian molecule desidustat, and this was received its first approval in the March in 2022, and these were the timeline of how desidustat went through all this. There was a study, DREAM ND in non-dialysis and dialysis population, which was published recently. And what about the in the phase 2 study, desidustat, they wanted to check it was a dose ranging study. They wanted to give 100 milligram, 150 milligram, and 200 milligram, and they found that the increase in the hemoglobin was much better when the dose was 200 milligrams thrice a week. But as very wisely, they have stuck to the 100 milligram dose because they don't want to get bitten by increase in the cardiovascular events. And so this is the phase 3 trial of desidustat of the DREAM-D study, where 390 patients were randomized in a parallel group active control trial. The comparator was epoetin alpha, and the duration was twice or thrice a week. So these patients were given 100 milligrams thrice a week for 24 weeks. And the primary outcome was a change in hemoglobin from the baseline. So it showed that the mean changes in hemoglobin was 0.95 in the DESI group, whereas 0.8 in the epoetin alpha group. So it was non-inferior. The safety profile was comparable. So at this stage, I think we should all congratulate our own pharma industry, because it is not common for pharma industry to come up with a molecule which is in the front line of development, in the cutting edge of nephrology, and also provide very good results. And I also remember the Zydus providing us with another molecule called saraglitazar. I have been a great fan of that molecule right from the time, because this was a molecule which was used to with good effect for reduction of triglycerides. And with every patient I have had excellent results, and I am sure the audience also will agree with me. So this is a longitudinal study of DESI in our own unit, where we aim to study the effect of this molecule in the change in the hemoglobin at the end of 3 and 6 months, because these are all early days, and also study the side effect profile. And so we had a baseline hemoglobin and also iron studies in these patients, and we went ahead. Mostly we did it on patients on dialysis, very small number, only handful of patients on the pre-dialysis group. And we screened 210 patients, 209 on maintenance hemodialysis. On DESI we had 169, and we had to exclude 30 of them, and the final number was 139. 52 females and 75 males. So number of patients on recombinant erythropoietin was 41 when we had changed it. So so we didn't give 100 milligram 3 times a day, 3 times a week. We had only weekly twice. So 125 patients. Because of the economic reasons, we are only giving it on a supervised regimen when they are on dialysis weekly twice, and the other dosages were seen in only 7% of these patients. So we are able to get a good improvement of hemoglobin above 1 gram in 75% of these patients, and 25% I am sure they would have required 100 milligram 3 times a week. The primary outcome, the initial hemoglobin was 8, and after 3 months it came up to 9.2, which was statistically significant. In patients with no improvement in hemoglobin, around 24 of them, so we had to increase the dose to 100 milligram 3 times, and of these they are sure to respond, and some of them were really resistant, 14% of them, and non-compliance was there in 6% of these. What about the side effect profile? I am sure all of you are very much interested in knowing that we should not do any harm because of the problems which have been encountered in large-scale studies. So one of them had a drug allergy. 4 patients had degrees of hyperkalemia which could not be explained by other features. So this is a note of caution for all of you. Hyperkalemia, please keep a watch. This was not a major issue in many of these large-scale studies across the world, possibly because of the fact that they are all weekly thrice dialysis. Indian patients are dialyzed only weekly twice, most of them, at least in my unit. And so potassium has to be monitored. So keep a watch on that. and then venous thrombosis. So these two are the issues that I would like to highlight. And so we need to conclude that desidustat can be used to treat anemia in CKD patients effectively, and this is not an RCT. So the potential benefits, Dr. Rajgopal was asking us, should we throw away the erythropoietin and latch on to orally available drug? The advantages are that oral route increases, benefits, maintains the hemoglobin levels effectively, and most important point, that increases endogenous erythropoietin production in a physiological range. It has been shown even by the lectures by Dr. Singh that the erythropoietin levels are kept under physiological range, whereas when you give exogenous erythropoietin, it can go up, regulates the hepcidin and increases the iron absorption. So there are multiple known unknowns. All these, the factors, the direct transcriptional targets of HIF, starting from angiogenic signaling, vasomotor regulation, matrix and barrier functions, all these are there, I agree. And so the nephrology community has been once bitten by erythropoietin molecule, and so we are twice shy. The potential upregulation of all these hypoxia sensitive genes, glucose regulation, angiogenesis, cell proliferation, elevation of liver enzymes. In fact, there was a fatal hepatic necrosis in a patient who was started on this. And the safety concerns, there has been no increase in the BP so far, no increase in the VEGF levels in the doses used, and all these are because of the short duration of clinical trials and insufficient to predict all possible side effects. So the molecule is out in the open. It is upon you to have a good look as to about the patient selection, and possibly I wouldn't select this molecule for patients who have a high risk of malignancy or already having a history of malignancy, and secondly, a patient who has had multiple thrombosis, even though erythropoietin, exogenous erythropoietin also is a risk. This is another factor which I will consider and stay away. Thank you.
Thank you, sir, for enlightening us about the HIFs, and I am sure it will be definitely a very useful molecule in future in the managing anemias. But do you advise any screening before prescribing these drugs for looking out for any tumors or any?
I wouldn't be on the watch for any tumors in these patients. So the risk is not been very well ascertained. So I wouldn't subject my patient for a wild goose chase of looking for small tumors and then starting. I wouldn't do that.
Thank you, sir.
Yeah.
I request
the discussion is open for the.
Any questions? Any questions to the speaker?
Hello. Thank you, sir, for that wonderful session. Sir, I would like to know whether I have a dialysis unit where we have a few pediatric patients, 3 kids. All 3 of them are scared of needles. So would you prefer me giving these drugs to them instead of EPO?
So they're all in the pediatric age group. I don't think we have the data on pediatric age group as yet. So I wouldn't be enthusiastic about using it.
Thank you, sir.
Dr. Sampath, excellent talk, and I've got a large number of patients on this, which I am very comfortable. And actually, the patient, another patient requests, that patient is getting that molecule, please give it to me also. I don't want injection. So that is a positive thing for the unit also. But my question is, some patients may not respond. Is there any role in mixing and matching a little bit of erythropoietin plus this, combining both, like once a week erythropoietin and or dabipoietin, and along with this add-on therapy?
Yeah, I wouldn't see there is nothing which prevents these innovations, and you can always use, because most of the trials have been done in such a way that they have mixed and matched, and so you can use it.
Dr. Sampath, I have a question.
Yeah.
What was the major problem with use of these drugs? Was it a cost, or because they are supposed to be cheaper than the erythropoietin themselves?
Yeah, see, cost is not a factor. If you see the cost analysis, it will work out cheaper. Yeah.
Thanks.
That kind of duration for the study? Any idea? Any thoughts?
Pardon me?
The phase 3 study duration was too short. I mean, I don't know how that regulator kind of came out with that. Any thoughts? Any
So
ideas?
I think Zydus will be the best person to answer this.
This is a point regarding the cost. Now, the problem in our area is erythropoietin is given free by philanthropists.
Yeah.
So when they are given a lot of unheard of molecules, erythropoietins. So the patient, wherever they get it, they go get it free, and then they come with a low hemoglobin. Then we give them, put them back on this. Patient is convinced, the hemoglobin goes up. Again, they stop because they have to pay for this while the injection is free. And always they have the feeling that an injection is more powerful than a tablet. So that is one practical problem which we've been facing.
If there are no more questions, we'll close this. Thank you, Dr. Sampath.
May I request?
Oh, she is on.
Madam, please go.
Excellent talk, Sampath sir. So only thing is, like erythropoietin, though we are getting it free under the government scheme, the problem is we don't know whether we are giving erythropoietin or water, because there is cold chain maintenance leaves much to be desired. And unlike the polio vaccine, which has a color indicator, and the color of the vaccine changes if the cold chain is not maintained, despite repeated suggestions to the companies, that has not been done for EPO. So that would be one of the major advantages of an oral drug. So again, the oral drug, again, I think we are all prescribing, but only thing is, it's always important to tell the patient that this is relatively new and these side effects might be there. That's the guideline as of now, because phase 4 studies are starting. We've not completed them, though it's approved by DCGI. So fantastic presentation. Thank you.
I couldn't but agree more with Dr. Manisha about this statement, because we are getting all sorts of erythropoietins in the molecules where the quality is not assured, and then we are probably inadvertently doing more harm by causing a lot of these patients to go into PRS, pure red cell aplasia, which is not an easy disease to cure. So in that kind of a context with, the regulations being so weak, just because you're getting a free erythropoietin need not necessarily mean it's a good erythropoietin. So that kind of a context, this molecule could be good.
Interesting point is that the first patient whom I had started this molecule was a patient who developed the anti-erythropoietin antibodies. And he was given tons and tons of erythropoietin. The hemoglobin was only 5. He was referred from some other center. I had started this molecule, and he made a good recovery. He never required.
It's not easy to treat a PRI. You need a
transfusion
plasmapheresis and the rituximab and all that. It costs a lot of money.
Yeah.
It is a very good, my experience also says, I started in dialysis patients who are not responding to erythropoietin. Almost we experience around 20% of the patient not responding to erythropoietin. They need supraphysiological dose of erythropoietin. In them, I have started almost more than 15 patients. They are doing extremely well, and their hemoglobin rise is more than 2 grams in 2 months. Probably the reason might be hepcidin levels, and reduced inflammation is also one of the contributing factor for good response compared to the erythropoietin.
Thank you, sir. There are no more questions.
May I request the chairpersons to hand over the memento to the speaker, Sampath sir. May I request Dr. Prabhakar, Konganad Hospital, to hand over the mementos to the chairpersons. Dr. Prabha. May I request the next speaker, Dr. Shivakumar, to the stage for the talk on PD mechanical complications, how to handle and manage. And I request